So hello, my name is Ulrich Schäfer. It is my great pleasure to host this session called Clinical Outcomes of the ALLEGRA valve in patients with aortic valve disease. The ALLEGRA valve is manufactured from VIVALL technology, and we have a great panel that is also consisting with Stefan Toggweiler from Lucerne and José Baz from Vigo in Spain. And I will start with the presentation dealing with the ALLEGRA valve for valve-in-valve implantation. So again, it's my great pleasure to present the one-year outcomes of a novel transcatheter heart valve to treat degenerated surgical valves. And the study is called VIVALL, what is a multi-center single-arm pilot study. My name is, as said, is Ulrich Schäfer, and I was appointed to be the principal investigator of this multi-center trial. These are my conflicts of interest. In the past, I've received grant and research support from VIVALL Technology and also obtained honorarium consulting fees from that particular company. So why was this study performed? So just looking at the stent design of the ALLEGRA transcatheter heart valve, with this tubular stent design, it is apparent to most TAVI operators that this stent might be particularly appealing for valve-in-valve implantation. The stent consists out of a short laser-cut self-expandable nitrile node stent frame. It carries a bovine pericardial tissue valve, being a tree-leaflet valve, and it has also 6 gold markers, which are radiopaque and allow for better visibility during implantation. In addition to that, the stent has some pole movement in the top to possibly translate into a better longevity regarding in the future for these particular valves. The valve, as said, is a supraannular valve design. It is self-expanding and is delivered via transvascular access through all commercially available 18-French sheaths. From in vitro testing and also a small clinical series, in the past we had good results which were pointing in the direction that the hemodynamics of this device are comparable to other CE-approved transcatheter heart valves. And due to these favorable properties of the ALLEGRA transcatheter heart valve, the VIVALL study was initiated to evaluate the clinical performance of this valve for the valve-in-valve indication. So what did we study? The multi-center VIVALL study was designed to investigate the technical feasibility, the safety, and the performance of this valve for treatment of failing surgical aortic bioprosthesis. The 30-day outcomes have been published recently in Neurointervention, but mid- and long-term data remain still to be investigated. So how was the study executed? The study was carrying the primary endpoint, what was defined as a 30-day survival, and the performance that was the invasive measured postoperative mean pressure gradient assessed by 2 pigtails with a simultaneous pressure recording. So in total, 30 patients were included in the study. The mean age was 78.6 years. The STS score was 4.5, and the Euroscore 2 was 9.2, indicating a higher risk TAVI population. All assessments were taken at baseline, procedure, discharge, 30 days, 6 and 12 months. And there was an independent combined data safety monitoring clinical event committee and also a core lab that adjudicated all adverse events of the patient safety and echocardiograms during follow-up. So in total, 30 patients were enrolled in the study and treated with the NVT valve. There was 1 conversion to Evolut R implantation due to migration of the ALLEGRA valve. So only 29 patients remained in the intention to treat analysis. During the follow-up, a few patients were lost due to missed follow-up visits. There were in total 3 deaths. So at 1 year, and this is now the talk, what is the talk dealing about, we had 24 patients remaining in the data analysis. So what were the essential results? Looking on the right side, we can see the primary endpoint, invasive mean pressure gradient, that there was a significant reduction to 11.6 millimeters of mercury, assessed by 2 pigtails. And interestingly, it is also apparent that this decrease in pressure was largely independent from the treated size of the surgical valve prosthesis. Of note is that 90% of the treated surgical valves were small bioprostheses with an inner diameter of 22 or less millimeters, and 43% of the patients were carrying a mitral prosthesis, what is known to be a very demanding and complicated prosthesis for valve-in-valve implantation. Looking now at the long-term follow-up regarding the echocardiographic hemodynamic assessments, we can see that there was a significant reduction in transvalvular gradient from 30.7 millimeters of mercury to 12.1 millimeters of mercury at 1 year, with the corresponding increase in opening surface area to 1.5 centimeter square. Also, the transvalvular or paravalvular occlusion was not a problem with this treatment approach. We can see there was only 1 patient with mild paravalvular aortic occlusion, and none of the patients had a more than mild aortic occlusion at 1 year follow-up. Together with the reduction in pressure gradients, this translated in significant increase in functional capacity according to New York Heart Association, with 79.3% of patients being in functional class 3 and 4 at baseline, and only 16.7% in functional class 3 at 12 months. In addition, the all-cause mortality was very low, with only 10% at 1 year. Of note is that there was no cardiovascular mortality at 1 year. So the causes of death were pancreas carcinoma, pneumonia, and 1 fatal road accident. There were 2 deaths before the 6 months visit was taken, and 1 additional death before the 12 months visit was taken. Valve failure requiring repeat procedures was observed in 1 case, with evidence of subclinical prosthesis, valve thrombosis, under treatment of rivaroxaban, that was detected at 30 days with a mean grade of 90 millimeters of mercury. And this patient remained without symptoms after changing his treatment to warfarin, and he remained without symptoms since. So what are the essentials to remember from this trial? I think we can state that the safety and efficacy of this valve design was shown in the VIVALL study. We all do know that many patients with failing surgical bioprosthesis have an increased risk for surgical reoperation because of higher age and additional comorbidities, and it is also expected that the number of failing surgical bioprosthesis will increase significantly in coming years. In conclusion, TAVI systems with beneficial hemodynamics and proven safety outcomes, such as this particular valve design of the ALLEGRA valve, might be of significant benefit to spare elderly patients from redo open heart surgery. I want to conclude my talk with a little view in the future. So what might be interesting with regard to this valve-in-valve implantation? And we have all learned from the past that bioprosthesis fracturing might be an approach for especially the small bioprosthesis. And this is just showing you an example of a patient that was treated recently with a degenerated Carpentier-Edwards porcine SAV valve being labeled 21 millimeters. And the balloon fracturing in that particular case resulted in a significant additional reduction in gradient, as shown on the right side. And I think the stent design of the ALLEGRA device is particularly appealing for this approach of balloon fracturing in addition to valve-in-valve treatment. And with that, I'd like to thank you for your attention.
Welcome to this session about the ALLEGRA transcatheter heart valve. My name is Stefan Toggweiler. I'm interventional cardiologist from Lucerne, Switzerland, and it's a real pleasure to show you some of our cases and our experience with the ALLEGRA transcatheter heart valve. These are my disclosures. So I would like to start with a case presentation. This is an 81-year-old gentleman who presented with severe aortic stenosis. The mean gradient was 53, the aortic valve area 0.9. There was no relevant coronary artery disease and the ECG was normal. So the treatment plan was to implant the 31 millimeter ALLEGRA valve with 24 millimeter balloon pre-dilatation. And as it is now routine in our center, we also use a sentinel protection device. So on the left side, we see the 3-cusp view. And on the right side, you can already see the permaflow position of the valve. Now, initially, we go quite deep in the ventricle. Then we open the middle part of the valve to reach this permaflow position. And then the first operator slowly pulls back the catheter until we reach this target position, as you can see it on the right side. This is quite important. We want to make sure that the whole catheter has no tension, and this is important once we release the inflow of the valve. I usually like to check the position on rapid pacing, as you can see on the left side, and on the right side, we then release the inflow, and usually the valve will remain quite stable. And once we have a good position, we can fully deploy the valve, and you can see the final angiogram here, and also the echocardiographic result with no or trace paravalvular leak and the mean gradient as low as 5 millimeters of mercury. So the ALLEGRA transcatheter heart valve is a supraannular bovine valve. It has a 19-hole frame, a little bit shorter than the Evolute, and it's available in 3 sizes, 23, 27, and 31 millimeter. These 3 sizes cover a range of annuli from 19 to 28 millimeter mean diameter. The valve has radiopaque markers, 6 radiopaque markers for orientation. It has a barrel-like shape, and the tip of the valve is mobile. The tip of the frame is mobile, aiming to reduce stress applied to the leaflets during diastole. The inflow has a 12 millimeter sealing area. You can see the concept here. So the valve will slightly move inwards, or the frame will slightly move inwards during diastole, aiming to reduce stress applied to the leaflet and hopefully to increase longevity. Of course, we have to wait for several years, but at least that's a concept that is also used in surgical valves and hopefully will prolong longevity. The delivery catheter is 18 French for all sizes. This is the housing. The shaft is 15 French. And the valve is released by a squeeze to release mechanism. And there is a locking mechanism to guarantee safe release of the valve. So this is our experience of the first 73 patients we have treated in Lucerne. These are consecutive patients. As you can see, there are 60% women, mean age is 80. There is also some with the valve-in-valve procedure and also TAVI in TAV. I will show you some of these cases later. 23% have diabetes, 90% hypertension, and we also have done some bicuspids, and only 8% had a prior pacemaker. STS score was a little bit less than 4. Transfemoral access was chosen for all patients. Usually we perform the procedure in local anesthesia with no or minimal sedation. Pre-dilatation was done in almost all patients. So the valve, the radial strength of the valve is not extremely high, and therefore usually pre-dilatation is recommended. You can see the distribution of the valve sizes here. So most frequently the 27 millimeter valve was used. Post-dilatation was required in a quarter of patients. A sentinel protection device was implanted or used in a bit more than 50%. And the median procedural duration from puncture closure was 55 minutes. So on the right side, you can see our results, 30-day results. The new pacer was required in 4 patients, which is 5%, so quite a remarkable low rate considering that this is a self-expanding valve. Also 27% had a new left bundle branch block, and you can see the timing of occurrence here. So it's mainly during pre-dilatation, a few during valve implantation, and 1 patient during post-dilatation. A major vascular complication occurred in 10%. Maybe I want to add that we are 100% transfemoral center, so we also do very narrow anatomies with the transfemoral approach. There were 3 strokes, 2 deaths at 30 days, and the median duration of hospitalization was 4 days. Let's look at the hemodynamics, and we can see that the gradient was reduced from a mean of 48 to a mean of 7 after the procedure. So I think really low gradients, thankfully that it's a supraannular valve. And the aortic valve area at the same time was increased from 0.7 to 2.1. And only 10% of patients had a moderate patient-prosthesis mismatch, and there was no single patient with severe patient-prosthesis mismatch. So now I would like to show you a few examples of patients we have treated with a valve. One patient had a degenerated SAPIEN XT valve, 23 millimeter valve, 6 years after implantation. You can see the valve was a little bit underexpanded. There was a mean gradient of 46 millimeters, and there was also some transvalvular regurgitation. You can see initial positioning here, pretty similar to a native valve procedure. Again, with release with rapid pacing. Of course, here we did not pre-dilate the valve. And then you can see the deployment on the right side. Next slide. And in this TAV or TAVI in TAV procedure, I usually like to post-dilate to ensure full apposition, especially because the valve inner diameter was only 20 millimeters. So post-dilatation was done here. And on echo, there was no paravalvular leak. And the mean gradient was 16, which is, I think, is very acceptable. However, after the initial procedure with the SAPIEN 23, the mean gradient was 9. So we do have a little bit higher mean gradient than with the initial TAVI procedure. This patient also 1 year after the procedure had to undergo PCI. You can see the stenosis in the LAD and in the circ, and it was really easy to access the coronary arteries through the frame and perform this PCI. So the second patient I would like to show you is again a TAVI in TAV. This time is a core valve, 26 millimeters, which was implanted in 2009. And of course, at that time, we usually deployed quite low, and then we pulled up the valve a little bit. You can see it's a low implantation. The frame was not so bad expanded, it was 20 by 21, the inflow. But what you can see on the left side is that the sinus is quite narrow. So we were a bit afraid of high implantation, and we did not want to occlude the ostium and also not the sinus-tubular junction. So we did go for a rather low implantation again, as you can see on the left and the right side of the screen. And again, we did a post-dilatation to ensure optimal apposition. And this time the gradient was really low, was only 10 millimeters of mercury, so similar to a native valve procedure. The final case, I would like to show you a cusp overlap implantation. You may have heard of the cusp overlap. It's mainly used with the Evolute. The idea is to isolate the non-coronary cusp and to overlap the right and the left coronary cusp. This is usually done in an areocaudal projection, as you can see here on the left side. And this also helps to open up the LVOT. So there is no foreshortening in the LVOT, and it allows for a more precise position of the transcatheter heart valve. So this implantation and also the last few implantations we have done in this cusp overlap projection. And you can see on the right side the first step. So we open up the middle part of the valve. Then we pull the catheter slowly back until we reach this really stable position, as you can nicely see on the left side. Now the patient here, thanks to this permaflow position, the patient is really stable, so there is no need to rush and to hurry. So you can really take your time to reach this position. And once you're happy, again, I like to confirm the position with rapid pacing. And if that's good, deploy the inflow of the valve. And then once we are happy, we also deploy the outflow and then check the final result. So in summary, the Allegra is a supraannular bovine tissue transcatheter heart valve. It has a very nice shape that sort of makes it an ideal valve for valve-in-valve and also TAVI in TAV procedures. The supraannular position results in really low gradients. As you can see in our series, the mean gradient was 7 millimeters of mercury, and the rate of patient prosthesis mismatch is really low with this valve. Also, considering that it's a self-expanding valve, the pacing rate so far in our center are really low, and that's quite remarkable, I think. PVL rates are acceptable in the range of 3 to 4% moderate PVL. But of course, this is a small early experience and there is more data needed to draw firm conclusions. So with that, I would like to thank you for your attention and for attending this session. Thank you very much.
Welcome, everybody. I'm Dr. Baz from Hospital Álvaro Cunqueiro from Vigo in Spain. And I will talk about our experience using the ALLEGRA transcatheter valve in our hospital. And after that, I will talk about some cases done in our hospital. This is my disclosure. So as a background, everybody knows that TAVR procedure is increasing worldwide, and with the new evidence in the valvular heart disease management, will be the standard of care to treat patients with severe aortic stenosis, regardless the risk of them. In Spain, this rate is growing in recent years, and our hospital is located in the region with the best ratio of TAVR implantation in Spain. As you can see, the average of Spain is 91 implants per million inhabitants, and in our hospital, in our region, we have 178 implants per million of inhabitants. In our hospital, began with the TAVR implantation in 2008, and for several years, we have a plateau of implants with 22, 23 implants per year, but in the last, since 260, we changed to another hospital, new hospital, big one with a service of cardiology more important, and the implants was growing. We decided in 2017 incorporate a new device to our portfolio of TAVR and look for a new one with optimal characteristics. We search for a TAVR with good hemodynamics, supraannular, good profile and security, and a good radial force. We decide to choose ALLEGRA as a new valve to implant in our patients and find some points that make it different. One are the markers to set free the ostia of coronary arteries, the hemodynamic stability with the permaflow system, a quick release, and inspect long-term durability because it's done with bovine pericardium and with the movement of the outflow of the scaffold of the valve. But always, when we start with a new device, this means a little stress in the cath lab until the learning curve is not completed. We overcome that situation, and we have just implanted more than 160 ALLEGRA valves in our patients. ALLEGRA has CE market since April in 2017, and we implanted with this valve in November of 2017. I will talk about our first 145 patients. These are male in 45% of the cases, with a mean age of 83.4. As important, previous cerebrovascular accident in 6.2%, peripheral vascular disease 6.2, chronic pulmonary disease 2.8, porcelain aorta 2.8, previous pacemaker 0.3, which is very similar to the data of Esteban, and previous valvular surgery, mitral aorta in 3.4% of the patient, with previous atrial fibrillation 27%, and with previous coronary artery disease 16%, with PCI in 18 and CABG in 6.9%. The mean Euro score 2 was 6.7, and the mean STS score was 4.5. Related to the procedure, we use conscious sedation in all of the patient in 100%. The valve distribution per sizes is 18% with 23 size, 50% of 27, and 32% of 31 size. We use predilatation in 85% and post-dilatation in 27. We have to use more than one device in one patient, 0.7, and the procedural success was 99.3 because in one patient we have ventricular embolization and we have to send them to surgery. The oral anticoagulation post-procedure is in 48.5%, and related to the complications, we have 90% of vascular complications, stroke 2.9, a new pacemaker in 19% of the patients. Related to the basal ECG, in patients with normal ECG, previous to implantation, we have 15% of new pacemaker. If the patient has a right bundle branch block, we grow to the 46%, and with left bundle branch block, 27.3%. Related to the follow-up of in-hospital patients, we start with a mean gradient of 46.5 millimeters in the aorta, and after the implantation, the mean gradient was 7.18 millimeters. The ejection fractions didn't change before and post implantation. As other complications, like acute kidney injury, 7.4, knee onset atrial fibrillation, 22%, knee transfusion, 3.7, atrial regurgitation, mild, 93% of the patient, and more than 2 in only 1 patient. The mortality, hospital mortality, was in 2 patients only of 145 is 1.4%. Related to the mortality, our mortality at 1 year was 7 patients with 93.8 survival at 12 months. And with the 3 years follow-up, we have 9 deaths. 3 of these 9 patients was due cardiovascular origin, 2 by a stroke, and 1 by a sepsis after cardiac surgery due to TAVR embolization. This is the patient that I told you before. 4 patients died due to sepsis not related to the TAVI procedure, and 2 patients due to cancer. And related to the quality of life of the patients, in the baseline, 99% of the patients was between 1 and 3 class of NIHA, and after 1 month after implantation, 99% of the patients are between 1 and 2 only, and at 12 months, 70% of the patients are in class 1 of NIHA. Now, I will talk to you about 2 challenging cases that was done recently in our hospital. The first is a 74-year-old woman with lipidemia, hypertension, and on dialysis since 2020 and 12, with leukopenia and thrombopenia, hyperparathyroidism, obstructive sleep apnea, was intervened in 2013 with Edwards Magna 21 in the aortic position, and now has dyspnea class 3 with orthopnea. The ejection fraction is 68% and has degenerative aortic stenosis with peak velocity of 4 meters per second and radius of 67 and 44.5. The coronary angiography with not obstructive coronary disease, and was programmed for TAVR in a valve-in-valve procedure. Next, this is the imaging of the Edwards Magna with the X-ray appearance and the sizes, and with the application, the APP of valve-in-valve. Next, the selected valve is ALLEGRA 23. This is the CT analysis where we see that the left coronary artery is too low, 5.6 millimeters, but in the axial axis, the distance from the valve to the origin is 5.8 millimeters. The right coronary artery is also low, but the distance to the annulus of the prosthesis is more high, with 8.8 millimeters, and the sinus of Valsalva is also wide, so the risk is acceptable for implant a valve in valve. The challenges of this case is that it's a valve in valve procedure with low coronary origin. The left coronary artery has moderate risk of occlusion, but the wide sinus of Valsalva and the height of the prosthesis can difficult the access to the coronary arteries. So next, we began the procedure doing an angio, and we see that the risk of occlusion is not so high, and we decide to implant the valve without protect the left coronary artery. This is the release of the permaflow, and this will be the final position. We align the valve with the scaffold of the previous bioprosthesis, and when we deliver the outflow, the valve has a little tilt, and this is the final position. This is first angio with moderate regurgitation, and we wait 5 minutes and do another angio, and this is the final result with mild regurgitation. This is the second case. It's a 80-year-old woman with hypertension, persistent atrial fibrillation, asthma, and a cancer history of breast cancer and endometrial cancer in 2015, and with frailty very important. The cardiac history is a patient following outpatient clinic by progressive aortic stenosis, actually in class 3 dyspnea with orthopnea. In the echocardiogram, normal ejection fraction and gradients of 54-37 without stenosis in coronary artery, and with STS score of 5.1 and Euro score 2 of 2.24. The CT scan shows information that is a good patient to implant, but when we see the angle of the annulus is an horizontal aorta with a vertical annulus of the valve. This is the size of the annulus and the LVOT that show us that the valve that we have to choose is an ALLEGRA 27. Next. This is a basal ACG with bifascicular AV block, and the challenges of this patient is the horizontal aorta and this ACG. We align the valve in cusp overlap view with the line that crosses from the cusp to the annulus of the marker of the prosthesis, and implant the valve with rapid pacing and do an angio coplanar view to see the alignment of the valve to the left coronary sinus. After that, the position is good for us, and deliver the valve. And this is the final angio in the coplanar view with mild regurgitation and a good position of the valve. And 24 hours, the patient has the same ECG with atrial fibrillation and bifascicular block. So thank you for your attention. I hope that this session will be very interesting for you, and this information of the ALLEGRA valve will show you a new actor in this scene of the TAVR procedure. Thank you.
So dear colleagues and friends, it's my pleasure now to conclude this session, and I'd like to thank Stefan Toggweiler and José Baz for their presentations. I think we learned from all of the presentations that this stent design is of some interest for valve-in-valve implantation, for low coronaries. That was not actually addressed in my talk, but we had no coronary problem in the VIVALL trial. And also the gradients were in all three talks consistently low, with the supra-annular valve design. And I think all these findings point to an interesting property of this ALLEGRA TAVI heart valve design from new valve technology. Stefan Toggweiler nicely presented his single-center experience of 73 patients with very low pacemaker rates, with only 5% of pacemakers being implanted after treatment with this particular valve, and as said, with these very low gradients of 7 millimeters of mercury. José Baz showed a larger single-center experience with 145 patients, with a very high particular success of 99.3%, a higher pacemaker rate of 18.9%, and also a very low gradient of 7 millimeters of mercury. In addition, he found also very convincing low numbers of aortic augmentation. And to come last, in my presentation, I think we could also present that this valve design is particularly interesting for valve-in-valve indication, with very good outcomes, very low complication rates. And I think this is something that points in the right direction in the future. So I think there is a great potential for that particular valve design. I might thank again all the attendees of this new format in PCR. I think this is something we have to learn, how we have to deal in the future with this kind of problems in these pandemic situations. And I'd like now to conclude this session and also like to give a little glimpse in the future that new valve technology is also working on a new catheter design that will be also tested in the very near future in an additional trial. So again, thank you for your attention.